So welcome to the conversation. We wanted you to know that all the participants will have muted video and microphone during the conversation. There'll be a 15-minute question and answer after the discussion. And please post your questions using the Q&A button on your screen. There will be slides and recording of the conversation, which will be available in 1 week on the Race, Gender, Science, and Medicine website here at the Hutchins Center. You can see the URL there. And after the conversation, please continue to send questions also to RGSM, Race, Gender, Science, and Medicine at fas.harvard.edu. And also we'll begin to place some suggested readings from each conversation, which will also be available on our website. So let's turn to today's conversation. I'm going to try to share my slides with you. And I just wanted to make one other point about the Q&A. So during the conversation, we like people to use the chat function for comments between participants only. And during the Q&A, which will be the last 5 minutes of our discussion today, that'll be for short questions for the speakers to myself or Professor Hogarth. So let's get started. So thank you for your attention. So today, as you all know, there are many discussions happening all over the world that focus on some aspect of the coronavirus pandemic. But our focus in these conversations is a very specific one. This is a series of conversations with leading scholars in public health, the history of medicine, and African American studies that delves into the historical and contemporary impact of epidemic diseases on African American communities in the United States. We held the first conversation last week where I was joined by Professor David Williams, who holds appointment in the Harvard T.H. Chan School of Public Health and Sociology and African American Studies here at Harvard. And David is one of the world's leading experts on health disparities in African Americans. We had a wonderful conversation last week. Today, we look at another aspect of the ways in which African Americans have long had to deal with respect to epidemic diseases, and that has to do with what we call the myth of Black immunity. And we are lucky to have with us today Professor Rana Hogarth, and she wrote a really wonderful paper in the American Journal of Public Health, The Myth of Innate Racial Differences Between White and Black People's Bodies, Lessons from the 1793 Yellow Fever Epidemic in Philadelphia, Pennsylvania. Just as last week, the headlines began to reflect some of the issues that we are concerned about. Let me return just for a moment to some of the headlines and just an article I want to draw your attention to. Yesterday or so in the Baltimore Sun, Baltimore City plans coronavirus ad campaign to combat the myth that African American residents are immune. And also a recent paper appeared in the Journal of Racial and Ethnic Health Disparities, which was entitled The COVID-19 Pandemic, A Call to Action to Identify and Address Racial and Ethnic Disparities, which also confronted the issue of the myth of Black immunity to certain kinds of diseases. Certainly in the Baltimore case, you will see that the Baltimore Public Health Department has begun a series of ad campaigns, ideally to address African Americans who seem to believe, at least the health department thinks they believe, that there are many rumors around the community that Black people were immune to coronavirus, and therefore not necessarily following the safety precautions that have been instituted. There's a long history to this notion of the myth of Black immunity, and that's what we're going to explore today. One of the most important texts about the yellow fever epidemic that we'll use as part of our case study to jump off into a discussion about the myth of Black immunity is from a really wonderful edited volume called A Melancholy Scene of Devastation, The The Public Response to the 1793 Philadelphia Yellow Fever Epidemic, edited by J. Worth Estes and Billy G. Smith. And they note, in modern America, where triumph over disease is often taken for granted and yellow fever ceased to be a menace, it's difficult to appreciate the fear once engendered by this disease. The 1793 yellow fever epidemic was no mere round of sickness, they continued, but a major public health emergency that paralyzed city functions, halted business and trade, and caused a breakdown in social institutions. The fever's devastating effect on what was then our nation's capital is apparent in the grim statistics. More than 17,000 people fled the city, and nearly 5,000 died, and hundreds of children were orphaned. Just a note about yellow fever before we proceed. Today it's known as a viral disease of typically short duration. It's spread by people infected by the bite of an infected mosquito. The illness ranges from a fever with aches and pains to severe liver disease with bleeding and yellowing skin and eyes. In 1793, it was equally visible, and physicians understood it to be marked by headache, pain in the abdomen, black vomit, yellow skin and eyes, and nosebleeds. But however, some victims, even as today, showed very few symptoms. So what I wanted to do is now turn it over to my colleague who's with us today. Rana Hogarth is Assistant Professor of History at the University of Illinois. Her research focuses on the medical and scientific constructions of race during the era of slavery and beyond. She's the author of a quite wonderful volume, Medicalizing Blackness, Making Racial Differences in the Atlantic World, 1780 to 1840. So I wanted to begin by asking Rana to tell us how white physicians in the 18th century came to believe that Black people were immune to yellow fever.
Okay, well, first of all, I want to just say thank you so much for inviting me to participate in this conversation. I think it's an important one, and I'm very happy to share a little bit of my research and hopefully give us a little bit of a historical lessons on the dangers of assuming such a thing as innate Black immunity. What I want to do is just very briefly, I have a couple of slides that I just want to show that will, I think, directly get to some of the questions and some of these themes, specifically addressing the issue of how it was that white physicians started to believe that Black people were immune to yellow fever. And this is being innately immune to yellow fever. So what I want to do is I'm going to go ahead and pull up some slides here. And I just want to see if everyone can see my slides. Is that present for everyone to see?
Not yet.
Oh, okay. Let me see if I can go back. I want to make sure, because this is something that I think will be useful for everyone.
Yes.
And I want to see if now.
There you are. And
okay, great.
Full screen mode.
Okay, I will go ahead and. There we go. Fantastic. Hopefully everyone can see now. So what I did for the research for my book was actually to read through a number of medical treatises from the 18th century. Which is where I found a very robust paper trail in which I saw physicians make sort of an indirect reference or observation that Black people seemed to not suffer from yellow fever. Now, as was sort of stated before, yellow fever was noted for its telltale signs, jaundice, also known as the black vomit. It was a very gruesome, very visible, visually distinct disease. The understanding was at the time was that for people of African descent, there's this observation that they just did not seem to suffer from this disease. However, white settlers, newcomers specifically coming into the Americas, the eastern seaboard, tended to be most vulnerable. Mm-hmm. Now the issue is, of course, we know that this is caused by the bite of the Aedes aegypti mosquito, but people did not know this in the 18th century. And the issue was for many physicians, particularly those that worked as port physicians, inspecting ships with captive enslaved Africans, they would have an opportunity to compare Black people's bodies to white people's bodies in a way that they clearly wouldn't have were it not for the slave trade. So right. What you see are what starts out as observations of comparing, okay, during times of sickness, during yellow fever, we're seeing a difference. Now the problem is, of course, is that we now know there is such a thing as acquired immunity to yellow fever. At the time they did not know this, the assumption was that there was something about Black people that made them not liable to this fever. Now this is actually This is significant in a number of levels. One, because it puts, this idea puts a burden upon Black people's bodies in the 1793 yellow fever epidemic. But most importantly, it also leads to the erasure of Black people's suffering during this episode in history. So I want to maybe take us back into some medical texts that actually show us how this particular idea took root. And one of the things that I really enjoy about being a historian is, digging through really wonderful, fantastic archives, but actually tracing an idea and seeing it evolve over time. And what I've provided for you here is simply the famous excerpt from Dr. John Lining, who noted in 1748, quote, "There is something very singular in the constitutions of the Negroes which renders them not liable to this fever," end quote. He's specifically referencing yellow fever. John Lining actually did indeed serve as a port physician in Charleston, which was a very busy port, receiving many captive enslaved Africans. And what he basically did was to say, okay, here it is. I have been through several yellow fever epidemics in Charleston, and this is what I have noticed.
Yes.
The problem, of course, is that he was incorrect. And this is one example of how physicians start to put this down to print, into paper, and it starts to circulate.
But he claimed to have had long experience with observing yellow fever in the South, and thought that he understood the problem, though it's not clear that he really did observe what he said he saw.
Yeah, no, it's unclear. I mean, he is, I think the other important thing for us to remember is that physicians at this time were inclined to see difference, right? They were actually looking for difference, I should say. That should be very clear. And so for him to single out and say that it is their race and it is this group of people is not terribly surprising, given this context and time. So I might go ahead and just move through, because I did want to actually start with this slide to show you what I mean when I say a paper trail, because Lining, it turns out, was respected by his peers. And he actually ended up catching the eye of one very famous Dr. Benjamin Rush, who perhaps anybody who is interested in history of medicine, or just in general has an interest in sort of Philadelphia history, probably knows about Benjamin Rush. He was a very well-known abolitionist and physician. But he was also considered to be a medical authority during the yellow fever epidemic that struck Philadelphia in 1793. And it turns out that Benjamin Rush actually read John Lining's treatise several times. And when yellow fever does appear in Philadelphia, he kind of quickly goes back to this text and says, okay, I know how to act and I know what I must do. Remember, yellow fever is something that everyone dreads. It's a terrifying disease. What Benjamin Rush does is essentially to call in his, I guess you could say, a favor, as he considered himself a very good friend of the Free African Society in Philadelphia, and actually a friend of Richard Allen, pictured here. He actually writes to Richard Allen and asks if it would be possible for him to get other members of the Free African Society in Philadelphia to stay behind and nurse the sick during this deadly epidemic, because he assures him that Black people do not get yellow fever. Now, I want to be very clear here when I say he assures him. He wrote a letter to Richard Allen in which it is stated, quote, "It has pleased God to visit this city with a malignant and contagious fever, which infects white people of all ranks, but passes by persons of your color." So as you can see, this letter is clearly cataloged in there at the Library Company in Philadelphia. I read through it and quite literally see a physician appealing to an African-American saying, okay, you're immune because I've read this medical literature. He is a medical authority. He writes this letter. And indeed, Richard Allen does stay behind. He does convince a number of the Free African Society to stay behind. I should add that I think at around this time, Philadelphia boasted somewhat of a significant free African American population, something like 2,000, 2,500 African Americans are in Philadelphia. And they do indeed stay behind and help with burying the dead, nursing the sick. Benjamin Rush actually instructs Richard Allen and Absalom Jones, another free African American preacher, in how to bleed. So bloodletting is the standard of care. They are basically nursing and staying behind, performing essential services to Philadelphia during this epidemic. There is a problem, of course, and that is that Black people are not immune to yellow fever by virtue of their race. And that's something that Benjamin Rush actually acknowledged afterwards. He actually says, I was led to believe that the Negroes in our city would escape it. In consequence of this belief, I published the extract from Lining's History of the Yellow Fever, as it had 4 times appeared in Charleston, South Carolina. So this, I should add, is a quotation coming from Benjamin Rush's 1796 account of the yellow fever epidemic, where he basically admits that he was wrong. Now, what's interesting, and this is really crucial, is that he does say, quote, they took the disease in common with the white people, and many of them died with it. I observed the greatest number of them to sicken after the mornings and evening became cool, end quote. But then he says, the disease was lighter in them than in white people.
Yes.
I met no case of hemorrhage in a Black patient. So clearly, he wasn't willing to say, okay, they're equal physiologically, they're just as susceptible. The suffering was less. So you still see him clinging to this idea that there's fundamental racial differences between Blacks and whites. It does not go away, even though he admits his error. And I should add, and this is sort of one of the last slides I have,
yes,
he actually mentions that Richard Allen, if you remember, as I mentioned, his friend that he writes a letter to, Richard Allen actually gets sick with yellow fever. Thankfully, he obviously survives. But he writes a letter, Benjamin Rush writes a letter to his wife and says, quote, the Negroes are everywhere submitting to the disorder. Richard Allen, who has led their van, is very ill. If the disorder should continue to spread among them, then will the measure of our suffering be full, end quote. So, I mean, this is, again, a case of Black people putting themselves in harm's way, in risk, taking on these risks. And this is sort of the outcome here. Richard Allen himself gets sick. So this is a very dangerous idea to start to traffic in this notion that Black people are not going to be ill or they're somehow immune. And it is something that this episode in Philadelphia sort of serves as a warning to us, that we should not be going down this road at all.
So, Rana, let me ask you another question about the comments from, certainly from Richard Allen, from Rush, that is. And we know that Richard Allen and Absalom Jones actually published a very important pamphlet, if you could say a little bit about that. And what was the response to the fact that the very Black people who were in Philadelphia, many of them stayed, many of them volunteered their labor. They thought that if they contributed to helping take care of the sick all over the city, white and Black people, that they would somehow be accepted into the community. So what was the response to their efforts?
So I should say, and I mean, perhaps this is not going to be surprising for many of us, but the reality is that several commenters, notably Matthew Carey, put forth a pamphlet in which he actually accused African Americans of price gouging, of looting, of stealing from households where they were sent to tend to the sick. And basically, there was a smear campaign launched against African Americans who, again, are risking their lives, staying behind and doing this essential work. Now, again, what's again great about being a historian is following that paper trail, and it is wonderful to see that Absalom Jones and Richard Allen would not stand by and let this take place, and they actually penned their own account of the late awful calamity in Philadelphia, in which they give their side of the story. And it's fantastic because, one, it is their voices, they are eyewitnesses to what's going on, but they also, at least for me, it resonates as a very clear, well-articulated moment in the historical record in which African Americans say, we are not immune to these diseases. We suffer just as much as anyone else. And there's just this wonderful quotation from their pamphlet where they basically say, you know, we were told that we were going to be immune to this disease. You know, we really wish that would have been the case because that's not what we're seeing at all. So it's kind of this very sharp, concise rejoinder, a way to push back against this damaging narrative. And I like to tell folks, you know, if you read this document, you can see one of these early iterations of African Americans having to sort of stand up and say, enough with these myths, this is not true. There's sort of a long history of pushing back against these kinds of damaging narratives. And of course, to say, you know, we risked our lives to do this. We are not going to stand by and have our reputations tarnished.
But did their response, I guess one of the more important questions, and I've been immersed in yellow fever for the last week, unlike you for many, many years, but I've certainly read a great deal about it. I can't seem to find anywhere where anybody else cites the fact that the African Americans had printed the document, which really, made their argument and refuted the claims of leaders of Philadelphia after the epidemic passed. And so they do fall into a long tradition of African Americans responding to inaccurate and specious allegations about fundamental differences in Black bodies. But do you have any notion or that anybody else going through the many other epidemics that happened in Philadelphia? There was another one in 1797, there's 1798, there's 1799. Does anybody seem to have taken their position to and given it some kind of credibility?
Well, sadly, what I have found in most of the medical literature after the 1793 epidemic, even with Richard Allen and Absalom Jones saying we are susceptible to yellow fever, and even with Benjamin Rush backtracking, is a consistent, at least thread in medical sources that continually reference Black people having less suffering and Black people being immune. In fact, one of the things I found for my book was to look at other treatises that had been published after about yellow fever, and you still see this reference to, oh yes, they're still vulnerable. I saw a medical dissertation in 1830 by a student saying, oh yes, they're still immune. And what I actually did find were people trying to come up with ways to make this wrong notion fit. And by that I mean they will say the reason why Benjamin Rush said he saw African Americans suffering or getting this disease was because they had been too long in a cool climate, and this had interfered with their natural warm climates, which they're accustomed to, and that rendered them liable to the fever. But if you keep them back where they belong, hot climates, they won't suffer. So these are the kinds of mental gymnastics that you would actually see in medical texts trying to justify this claim. And it's certainly, there are plenty of cases of this in medical treatises, dissertations, published works, spanning both in the UK, the West Indies or the Caribbean, as well as the Southern United States.
Yes. Okay. I think I think a question still that like I said, from my own readings over the years and certainly most recently, is to really try to understand what can account for this persistence of this idea. It's carried both by physicians, but then there's a way in which it sort of sediments into the culture, such that the very idea, because it marks the notion of fundamental biological difference between Black and white bodies. It's just one piece that sediments that idea, but it does. And so it seems that it became very, very difficult for any kind of counter argument to have any possibility of dislodging that notion. And here we sit in 2020, in the beginning of a very serious pandemic, and African American public health researchers are having to again say that we're dealing with something that is a specious idea, and some people like to believe that this is that there are these fundamental differences, and Black people don't get coronavirus. But then today, locating it as something in the Black community, Black people are carrying this notion as if it originated from African American communities, which it did not.
No. I mean, I think that's part of the things that's something that's really concerning for me, at least, is to, one, recognize that the medical tradition, or this tradition of sort of seeing difference and using race as sort of a shorthand or a proxy for explaining away differences in susceptibility, there's a long history of it, but we still keep doing it. I notice that a lot of times people will conflate, race and genetics and say, well, sickle cell anemia is a Black person disease. And I often think, well, that's not quite right, because there are people in the Mediterranean or in, the Middle East that can also have this too. It's more of something that's genetic and evolutionary. It's not that by virtue of somebody arbitrarily deciding, okay, you fit the category of Black and therefore this disease is a Black disease. But people still do this. We still collapse these meanings into race and parse diseases and susceptibility in this way. And so I was actually quite dismayed at the beginning of this, this pandemic, where I think people maybe were looking at Twitter or seeing some kind of social platform saying, oh, well, Black people are going to be fine. We don't get this. And I thought, okay, what? That's not true. That can't be true at all. And, now obviously look where we are, where now we're seeing that African Americans are being disproportionately affected in places like Chicago. So I'm thinking to myself, okay, this is dangerous. We just need to stop doing it right now. It is actually not accurate and it is not precise to use race in this way to do that kind of work, to say, okay, this is who gets it and this is who doesn't. There's far too many factors that are involved.
So you made a really good point in your American Journal of Public Health article, and you said, without explicitly naming racism as a possible factor in explaining poor health outcomes for racial minorities, we run the risk of framing health disparities in such a way that draws our attention to the bodies of those suffering under the disparities, rather than drawing our attention to why the disparities existed in the first place. Is there anything about what you studied and saw in what happened in Philadelphia that caused you to make that point? You also give another example to make that point. So if you could speak to both of those.
Yeah, sure. So I think really the issue here that I think people need to recognize is, again, we invest so much in this concept of race. And I think that if we want to use race, I think we have to think about how race functions in the context of a society and how people can be treated different based on their race, and how that is directly tethered to your health outcomes and how you experience the world and how you negotiate the world. So when people say things like, Black people are 3 times more likely to have X or 3 times more likely to have Y, right? This is something that we see in headlines. For me, I often say, okay, you now need to go a step further and say, Black people are more likely to experience a lack of access to care, to have discrimination in healthcare settings, to have these other factors that can contribute to them having 3 times the rate of X. Because if we leave it the way that we do, a person could wonder and say, well, maybe Black people are just that way, there's something about them, or that they don't practice good health behaviors, or it puts the burden on Black people's bodies. And this is something that we have seen throughout the historical record, and it's not useful. It's actually doing us a disservice. The issue is we need to name structural problems that contribute to negative health outcomes. And again, I'm not saying, I always want to be clear with people, look, you should notice differences when a physician sees a patient. They're going to note, characteristics, and that's fine. But don't attribute a health problem of saying, okay, this person has X disease, it must be because of their race. You might want to consider more broadly that person's life trajectory, especially in thinking about the American health system, where we're starting to see concerns about implicit bias in it, influencing poor medical decisions in terms of pain management, treatment decisions. Those all need to be factored in. So I always like to say, if you're going to say there's a distinction or there's a health disparity, maybe think about why it is and not just focus on the idea of race. Think about how racism then works in tandem.
So you do that in what you described as well about what happened in Philadelphia. What you draw out in your paper is to show how little people made note, observers at the time made note of the actual conditions under which the African American community was living at the time. We know that Philadelphia was a city at the time where it's a burgeoning city. It's the center of government at the time, but also it was a place where there's growing inequalities of wealth and class, and there's little that I've seen mentioned in the documents that note those other structural issues that you're referencing for today, even at that moment of time. The observers who are charting what happened in the epidemic aren't saying that much about the fact that they're very poor people there, the conditions under which the poor lived, and conditions under which many of the African Americans were forced to live.
Yes, I mean, I think that should be, I mean, it's true. If we can, people often think, okay, well, Philadelphia had a large free black population, and isn't that great? We have to understand that for free African Americans living in Philadelphia, they were not treated at all with any kind of sense of equality. They were subject to terrible housing. They were subject to terrible treatment. So, I mean, it's actually interesting for people who could flee during the yellow fever epidemic. They fled.
Mm-hmm.
If you were poor, if you were black, you didn't really have anywhere to go, right? You were basically trapped there. To recognize, and I think I noticed this actually in some lay writing. So this is letters that average people would write home, you know, or write to England to family members. They would make reference to sort of the so-called poor downtrodden blacks, and this is their chance to prove themselves, right? So there was even an acknowledgement sort of indirectly that this was a group of people that were marginalized, right? That were at the bottom of the social ladder. Oh, but now here's a way that they can possibly redeem themselves. And again, this is putting all of that energy and all of that burden on Black people to sort of have to prove themselves. And only then can they perhaps get that respect that they so desire. This is actually in part of a letter, I believe, from Susanna Dillwyn to her father. She was, again, opposed to slavery. But, you know, you have people who are opposed to slavery that are still holding these views
Yes.
of one, treating Black people as unequal and inferior, and then expecting them to have to prove themselves in these circumstances.
Yeah, and they did try to prove themselves, and their hope was certainly for Jones and Allen was that by offering themselves in the midst of this huge danger, that they would be recognized, and as I said earlier, be seen as part of the community. Unfortunately, that did not come about completely because of their efforts at the moment. But the other thing is that you've written about, certainly in your book, is that how the ways in which we evoke these sort of radical comparisons or racial comparisons between groups in medical discussions. And if you could say something about how often you saw that in the work you did in the early part of the early and late 18th century and into the 19th century, and why you think that there's so much of that, even beyond slavery.
Sure. Yeah. So I think comparisons abound in much of the primary source material that I looked at, whether it be you know, looking at disease susceptibility. Pain is also where this clearly stands out in the sense of people saying, okay, well, they bear pain much easier. This is also something that Benjamin Rush himself writes in one of his own published treatises. There's this impulse, again, I think, at this time period to see difference in saying, okay, all people have different constitutions. Even amongst white people, they'll say this person is of that constitution or this temperament. It was not actually surprising to me to say, okay, these folks are now comparing people who, you know, present visually differently, but they were really adamant about looking for internal proofs, even things that are intangible. So disease susceptibility is like, it's intangible, right? You can point to skin and say, okay, this is where I see the difference. But they went even further to say, okay, they're suffering something like not getting a disease or being immune to a disease. It was sort of, for me, watching as physicians tried to fit difference into their worldview and to back that up with these so-called observations. I would also add something that struck me as I was, you know, doing this research, is that I don't think many physicians were looking for yellow fever symptoms in Black patients. I don't think they were looking for that because they were told that they weren't going to see it. You know, in some cases, yellow fever can present mildly, depending on the case. It's very likely that some of these physicians didn't even bother to acknowledge that Black people were getting this. So committed were they to this idea of comparing these differences between groups of people. And so I still see this today, sadly, because I think there is still this impulse, especially in the medical field, of people wanting to compartmentalize a lot of information very quickly to make assessments. And I think that people still think that race is precise for doing that. But the problem is that it's not doing the work that you think it's doing. And it's actually using race as this marker for difference is actually, I think, obscuring far more than it is showing. And it is actually damaging because you then neglect, ignore, and assume actually that suffering has to be done in relative to another standard. And that's what I always found. The standard is, well, if this is what white people get, then Black people are not living up to this standard, which is problematic in and of itself. So this is sort of something that, yeah, it continues even today.
So I think, well, I think it continues today because of something that I think is very significant about the ways in which in US medicine, these constant comparisons between the races and raced bodies are such a part of medical theory and practice. And there's still, for some people, some historians writing about this have noted, there's an enduring appeal to kind of arguments that people whose ancestors have lived in different parts of the world possess innate differences in disease susceptibility, as my colleague David Jones has noted. And that these kinds of observations provide for some a kind of explanation for what are really complex historical phenomena, and can even suggest that particular outcomes, so to see more Black people dying is the expected outcome. So when they die, that's what you expect to see. Right. And it's somehow built into the worldview that constitutes the perception of difference that you were just referring to. And so I think that it indicates for many of us why these comparisons are difficult to confront. Well, not so difficult to confront these days, but very difficult to eradicate in many ways. So we have time for one more comment from you, and then I think we'll turn it over to some questions.
Yeah, I mean, I will just say very briefly, just in terms of the comparisons and the use of race, I do get the sense that I think how we are deploying race as a marker of difference is a matter of something that seems to be a catch-all phrase, and it's a shorthand that I think, as you mentioned before, there's so many other factors we have to consider. And I actually think now back to, there was quite a bit of a controversy about, saying, okay, well, if African Americans have more comorbid conditions, this might contribute to higher death rates of COVID-19. And so people would say hypertension, diabetes, et cetera, and then stop the conversation there as if it was something Black people are just prone to having these kinds of chronic conditions. And then I think to myself, okay, now finish up that thought and say, why do we do that? Right. So yeah, we can see this playing out just right now in sort of real time.
No, I absolutely agree. So let me see if we have some questions. Let's see, the first question, why do you think the death rate in New York in COVID-19 pandemic resembles so much what happens with other epidemics in the US, killing more Blacks and Latinx people? What do you think should be done for social justice in the future? We're getting much more attention to these social groups. You're gonna take part of that? I'll take part.
Yeah, I mean, so I have to say, I mean, something that I thought about, again, with looking at these numbers, and I know a little bit more about what's happening in Chicago, having lived there, and they're also seeing these extremely high rates for African Americans and Latinx populations. What I would first think of is just in terms of the social life and structure in which many minority groups are living in these densely populated areas, I thought to myself, okay, you have comorbid conditions, but I also thought about the idea of social distancing and the ability to do so in your day-to-day life. I can work from home. There are a lot of people that work as cashiers, as bus drivers, as essential roles that do not have this luxury. Some of these are maybe lower paying jobs that don't offer health insurance, also to think about that. And to think about, okay, what slice of the population inhabits those spaces? Are these people that have to commute to work? Do they own their own car? If you're having to go on a crowded subway, a crowded bus, or anywhere, if you have to be around people constantly at a time when we're saying stay away from people, that sets up for me the perfect storm for this vulnerable population to have these very high death rates. And I would imagine New York City being fairly dense, that the same probably might be true there.
So, I think it's very interesting that there's a lot of commentary in the news, social media, cable news about this, what you just described. What's striking to me, though, is that also many public health researchers are talking about the difficulty of even getting the data that is disaggregated by race and ethnicity to find out who's actually dying. And this is a point that many people have asked for this kind of data for a very long time, to the point where many public health researchers I was talking to earlier this week were saying, we thought everybody could just easily get that. We thought every public health department was posting that kind of information. We thought the CDC was posting that kind of information. And it turns out it wasn't being routinely posted everywhere. So that people simply, in some respect, being able to see the numbers was not broken out by race and ethnicity, was not something that was quite possible. And there's been a lot of calls for that to happen. The paper I was referring to by Cato Laurentian, he started looking at this in early February, and he couldn't get any data. And he was surprised. He's been at this work for a very long time, as was David Williams, who talked about some of this last week, and people were surprised. And so the thing that isn't surprising to those of us who either read the 18th century material, 19th century material, 20th century material, now in the 21st century, we have to start again by asking the basic questions. How many people and who are the people are most affected by what's happening in the pandemic? And that routinely, and we find yet another time that the government is not producing that that information in ways that makes it possible for us to see. So to the question, to the second part of the person's question about social justice, I think the fact that we want to institute and make possible easy access in any kind of disease outbreak for who's actually, who are the people who are most vulnerable, I think that we should be able to identify that in a very precise kind of way. And if it's not precise, why isn't it precise? Mm-hmm. And also have really official numbers which really describe who's at risk and who's dying. And then be able to produce preventative measures or measures to help people that prioritize the most vulnerable. So for me, I mean, the person's question is a good one, but I'm just shocked by the fact that we're asking some of the same questions we've asked for a very long time. The second question we have is, can we comment on the ways in which essential workers, especially in the medical field, the nurses, are being, orderlies, physicians are being constructed in medical and popular discourses during the COVID-19 pandemic as people suited to this work that is reflective of the history you've traced, especially African-American health professionals and workers? Do you want to take a stab at that, or we could?
Sure, I want to make sure that I am sort of understanding the question correctly. So I'm getting the sense that it's sort of for the people who are in the, that are sort of on the front lines in terms of healthcare professionals and providers, that they are somehow being constructed as being heroic or suited to this kind of work. Is that right?
She wrote how the ways in which essential workers are being represented as people who are suited to this work, and is that in any way reflective of the history we've been looking at, especially for African-American health professionals and workers?
Right. So suited, I mean, the thing is, this is the reason why I wanted clarification is because this terminology of being suited to a kind of profession has actually cropped up in very racialized ways in the past. And that's specifically having to do with the idea of nurses and Black women serving as nurses or Black people serving as nurses. That's something that I kind of, that kind of caught me in hearing that word suited, and constructing these people as this is the job they ought to be doing, which is where I kind of want to sort of pump the brakes a little bit. before suggesting that anybody is like sort of, this is their calling, this is what they must do or what they ought to do. I think for essential workers, I kind of think of essential workers and parse it into two different categories. So one, the people who are on the front line, healthcare practitioners, but then also when I think of essential workers, and particularly when I think about issues, I think again of social justice and race, I think of again those essential workers that are doing the jobs that people otherwise wouldn't think about, like wage working, they said bus drivers, cashiers, the people who are there at the supermarket when you don't want to be there, but they have to be there because they have no choice, and that is an essential function. And I think about what segment of the population is that group, and are they considered suited to that kind of work? So I always kind of, I always like to just be careful about the language, like what suited means in that sense.
I mean, I think there's also, probably a need to reference a lot of the work of people who look at the hierarchical nature of the medical profession, who is at the top, and people working in hospitals. I mean, it's one of the things that I'm constantly struck by when I actually have to go to the hospital and see doctors seem to be overwhelmingly white, but the people pushing the gurneys and mopping the floors and doing all these other kinds of work are predominantly Black and brown people. And I was just in another meeting this week looking at actually decline in numbers of African Americans, particularly African American males, going into and being accepted at medical schools. So what we see in terms of a low representation among physicians of people of color will continue if we don't increase the numbers of Black and brown people actually studying medicine. So we might continue to perpetuate a system where the hierarchy in the hospital is going to look like we see today. The poor and the people working in the lowest wage jobs being largely Black and brown people who are not necessarily recognized as having the potential to move up through that hierarchy, right? So let me see if there's someone else. I think we have time for about one more. This is a question that says, I am researching a yellow fever epidemic that broke out first in Boston in 1819 before spreading down the Eastern Seaboard. One physician in an essay published in 1822 wrote, quote, it has been fully shown by experiments performed for the purpose that the matter thrown from the stomach of a person in yellow fever does not of itself produce the disease in others, even when that matter is the true black vomit and is received into the stomachs of others. So I don't know where they saw this study, this grim experiment. They asked if you know of any documented experiments performed in the late 18th century in an effort to understand how the disease was transmitted.
Oh, okay. So that's actually, that's a fascinating question, because there is a huge debate versus contagionism and anti-contagionism with respect to the yellow fever.
Yes.
How is it spread? And so now experiments, like in the sense of a controlled trial, I've not come across somebody saying, okay, this is what the patient did and this is a case study. I know of claims, for example, right, when you have almost like these pamphlet wars where one physician will say, the people who changed the bed linens of people who were suffering do not get this disease.
Right.
Therefore, so I would say, looking back, so Benjamin Rush, I should say, was challenged by several other physicians. So I believe in terms of what kind of cures to use, is it contagious or not? There are a couple of ways to think about this. A secondary source that's maybe a little bit dated, but I think really good. I believe it is Martin Pernick, who has a short article about political ideology and contagion versus anti-contagionism. And I think in the footnotes, there might be sort of a way to think about medical treatises that talk about how people came to one specific ideology. And then he goes on to talk about Republican versus Federalist or ideas about if it's contagious, what do we do in terms of quarantine or shutting down the ports if it's not contagious, et cetera. But that was, I should say, that is a actually hotly contested issue, contagionism versus anti-contagionism, and it kind of stretches throughout the 19th century. And yellow fever was certainly one disease in which physicians did, argue about this. But an actual experiment with the black vomit, I do not know of any off the top of my head. I'm sorry.
Well, I'm glad you don't know of one. I hope there wasn't one.
Yeah, that's also a good point.
That's terrible. But one thing you can say about yellow fever, it is, and for people participating in the seminar, it has been the ways in which this yellow fever spread through the northern United States and then into the southern parts of the United States. Certainly there were many epidemics in New Orleans, really had a profound effect on every city and every region in which it struck. And a lot of the issues of what it actually meant about the people who were victims of it, the people who seemed to be, by whatever measure, observation whatsoever, not immune, are ones that were salient for a very long time. Debates about the acquired immunity or whether there was something imported into a particular place, how it was imported. There are discussions in port cities along the eastern United States, and then of course there are many in the Mississippi Valley and in New Orleans. And we haven't been able to do justice to the complexity of these outbreaks and the changes in ways in which it affected communities. I was hoping if we had twice or three times as much time as we have today, we could have talked about New Orleans, which is being struck again right now with the pandemic, and the whole history of poor African Americans who were and even enslaved, who were busy in all of those epidemics, were enlisted to bury the dead, to and many of them were so exposed to it, and how that played out in the whole context of New Orleans, which is a very different political, social, and cultural context than Philadelphia. But there are different issues that emerge in New Orleans, and then there are some that are quite the same. So at this point, I just want to thank Rana. Thank you for joining me today and talking with us about this. I think this work has been fascinating. You've really mined some of the more interesting features of what happened in 1793 that probably only a small group of historians of medicine have really ever talked about to great length, but it's really become important and very salient for us now. And so I want to end just by saying, if people have further questions, please send them to us. And we'll try to get to them, and we'll have a recording of our conversation on the website in a week. And next week, we'll have another conversation. And that one, I'll be joined by Professor Jim Downs from Connecticut College, who's written a wonderful book called Sick from Freedom. And we'll be talking about smallpox during and after the Civil War, and the huge impact that smallpox epidemics had on enslaved and free African Americans at that time. So thank you all for participating, and Rana, I hope to see you soon.
Yeah, thank you. You too.
Okay.